Hi, this is Elliot Fishman, and welcome to our latest edition of You Make the Call. You may remember it's a very simple game. I'll show you two images, one slide, and I need you to give me the best diagnosis possible. I'm not going to give you a set of choices, but we'll simply discuss the case. So without any further ado, let's get started. Patient with vague abdominal pain, and you see a tubular structure in the right lower quadrant. And here it is in cross-section. Now you could say, well, my goodness, this is a big appendix. And it's in that ballpark of appendix, so it is the appendix. But what gives you such a large tubular mass, but there's no inflammation around it? And this is a mucocele. It's a mucocele of the appendix. Mucoceles, if they rupture, patients get pseudomyxoma peritonei. Sometimes we see mucoceles when they're little tiny focal dilatations of the appendix. So you have to have a great level of suspicion. What else could this be? Another good thought here based on location would be a Meckel's diverticulum. So I think to me, I'm going to say there's a large tubular structure. I would follow it. Maybe I could tell it's the appendix, but if I couldn't tell for sure it's the appendix, I would say it's a tubular structure. Could be mucocele. Could be a Meckel's diverticulum, and this was a mucocele. Just a really, really nice example, an important diagnosis. This patient presents with pelvic pain and back pain. You see a large mass in the pelvis pushing the rectum and bladder forward. You can see the mass causes destruction of the lower sacrum and the coccyx. Now, what could this be? Now, you can have large rectal cancers growing posteriorly and invading bone, but there you see dystrophic calcification often, and here the colon is displaced. This is not arising from the colon. You could see metastasis to bone. That's a possibility. You can see tumors of the cord coming in and growing and destroying bone. I guess that's a possibility. But location, location, location. If you see a large solid mass, maybe with some faint calcification or dystrophic bone, and there's destruction and there's displacement, and it's located lower sacrum and coccyx, you got to be thinking about chordomas. This is where chordomas occur. The amount of bony destruction will vary. The amount of enhancement will vary. Typically, the lesions do not enhance much, and this is a perfect example of that. So the diagnosis, please, I think you should have said chordoma first. You could go through Mets, drop metastasis, rectal cancer. All those things should go through your mind, but they should be dismissed based on the appearance of this lesion. A very nice example of chordoma. This patient had cough, and what are we looking at? The key thing, or there's several key things. The hilar regions are attracted upward. Look how everything is pulled upward. So there's a fibrotic process going on. So I'm thinking about what gives me fibrotic processes. TB, sarcoidosis, radiation therapy, but this doesn't look like radiation therapy. And then there's a cavitary lesion with a solid component in the left upper lung. There's some air bronchograms present. So I'm thinking here of infectious etiology. TB is a thought. Sarcoidosis is a thought. You notice how the rest of the lungs look pretty good except for this retraction upward. Again, I'm not thinking malignancy. Other infections, coccidio, aspergillosis, classic aspergillosis in a sense, we're not thinking about that. It's not going to be COVID, obviously. When you have a cavitary lesion, patients are often immunosuppressed. But this retraction and then the cavitary lesion with soft tissue mass, you got to go through a differential diagnosis, and that's going to bring you to sarcoidosis. Sarcoidosis can be presented in many ways. This is one of them. Not capsular retraction, but lung retraction, hilar retraction, and often patients will get secondary infections with aspergillosis. A very, very classic case. This patient had back pain, and you see the soft tissue around the aorta. So the first thing you think about is there's a bleed present. And maybe it's intramural hematoma. For the image on your right, that's not bad. But intramural hematomas typically don't encase the branch vessels off the arch. And look at the left carotid, the left subclavian, even the right innominate. So what could this be? It could be retroperitoneal fibrosis. It could be fibrosing mediastinitis with infiltration. You got to think, could it be lymphoma just infiltrating the areas? Those are all good thoughts. But I still want to make certain I'm not dealing with an intramural hematoma. Now, of course, I've only given you 2 images. So you're thinking, what could it be? Vascular? Could it be neoplastic? Could it be inflammatory? What am I dealing with? So you got to think some more, and I would love to have more images. You can see when I give you the sagittal views how it extends down the aorta and into the abdomen, and you can see very nicely also the vessel involvement off the arch. But then if I only had more images in the abdomen, I would see infiltration of the kidneys. When I look at this case of infiltration of the kidneys, if I only look at the kidneys alone, I could say lymphoma. I could say extramedullary hematopoiesis as possibilities. Infiltration of both pararenal spaces and perirenal spaces, again, it's something diffuse. But then there's also the encasement of the aorta, retroperitoneal fibrosis, but it's a bit too much in terms of the kidneys. The kidneys would be retracted medially with retroperitoneal fibrosis. The disease that gives you perirenal involvement, pararenal involvement, as well as in the thoracic and abdominal aorta, is Ernheim-Chester disease. That's an unusual diagnosis, but you need to know it. We see it a couple times a year, and these patients are often misdiagnosed, but you're able to make the right diagnosis. They're treated with different therapies, including methotrexate, and can do well. Ernheim-Chester disease, here was an article from the Mayo Clinic. Aortic involvement, ascending aorta and arch, descending aorta. The aortic branch vessels can be involved, and this perinephric infiltration with aortic disease allows you to make the diagnosis. Again, emphasizing periaortic infiltration, which is usually circumferential and non-occlusive, as you would think about in retroperitoneal fibrosis. And any vessel from the aorta, from its root, through the iliacs, or everything can be involved. And again, the perirenal involvement, again, bilateral, often symmetric, makes you think of lymphoma, makes you think about extramedullary hematopoiesis. Just a wonderful case. This is an interesting case. There's a mass with very poor margins in the right upper lobe. This was a younger patient, so they were, let's say, low 30s. And the patient has extensive adenopathy in the right paratracheal region and in the anterior mediastinum. When you look at this, it's very easy to call this a lung cancer, and I would surely worry about this being a lung cancer and adenopathy. Of course, I'd like to see the rest of the image. Is this the only lung mass? How extensive is the adenopathy? What's its distribution? Those will all be critical findings. I show this case in part because you also need to say, well, could this be inflammatory? Could this be TB? Every once in a while we see sarcoidosis, particularly with a interstitial spread pattern. But I'm sure when I'm looking at this, my first thing is this is lung cancer till proven otherwise. When you look at the images and you end up with the biopsy, this ended up being sarcoid. Now, the next set of images, this was the ones I showed you with the adenopathy, the mass, irregular borders. You can see the adenopathy was fairly extensive. It was a younger patient, and it looks like spread from the hilar regions. This could be lymphoma. It could be lung cancer, maybe a small cell lung cancer. This was sarcoid. Sarcoid is a great mimicker. Lymphoma is a great mimicker. It can be very challenging. This patient was fortunate. The patient had sarcoidosis. This patient presented with abdominal pain and GI bleed. And when you look both on the axials as well as the volume rendered coronals, there's about a 3 centimeter solid mass with slight enhancement in the stomach. Well, what could you think about? Well, you surely need to exclude a malignancy. Could this be a cancer, gastric cancer? If it's not a gastric cancer under malignancies, could this be lymphoma? Lymphoma is usually infiltrating, not a polypoid mass. That would be unlikely. It could be a GIST tumor. Gastric GIST tumors are usually exophytic, but they can be intraluminal, or they can be both intraluminal and exophytic. You could also think about a polypoid lesion that's benign, like a leiomyoma or other fibroma-type processes. It could be metastasis. I've seen renal cell metastasizing to the stomach. So you're thinking malignancy. You want to exclude an infectious or inflammatory etiology. We've had stranger things. Okay, this enhances. Could it be an ectopic pancreas? That's a thought. Could it be a carcinoid tumor? Neuroendocrine tumors are indeed a possibility. This will get biopsied and eventually resected, and this ended up being a GIST tumor. Again, I would have considered carcinoid, GIST tumor, ectopic pancreas if I wanted to be fancy. Adenocarcinoma I didn't like. So this was a GIST tumor, a really, really nice example of an intraluminal GIST tumor. Again, this case also shows you the importance of good gastric distension and the importance of IV contrast material. This is an interesting case, 2 images. The first image is through the stomach, and I think you can see that there's an infiltrating process in the stomach. This is going to be a malignancy. Yes, you can say, well, it could be inflammatory, but it's focal. I think you're thinking here adenocarcinoma, occasionally lymphoma, maybe metastasis, a really unusual rhinitis plastica. You also see in the first image ascites, so the tumor has spread. Again, Mets is a possibility, and then you go down into the lower abdomen, and there's a large complex cystic mass. Now, what you can't say from this one image is the mass in the mesentery, or is it coming out of the pelvis? And I'm going to tell you this is coming out of the pelvis, and this was a female. So now you have a large pelvic mass, probably ovarian. Again, you would look, because it could be uterine in theory, but it looked ovarian, and you have a mass in the stomach. So I wanted you to think about what gives you a gastric mass and an ovarian mass, and the diagnosis would be a Krukenberg tumor. The metastasis from Krukenberg tumors, gastric adenocarcinoma is the most common. You could also think about bile duct tumors, other mucinous tumors. Mucocele of the appendix can go to ovaries. Often it's bilateral ovarian involvement, but it can be unilateral. The Mets can be small or they can be huge. This was an example of a huge tumor. In fact, the presentation, I believe, was abdominal distension, and the concern was a primary abdominal mass or GYN tumor. But this ended up being a Krukenberg tumor, a really nice example with gastric adenocarcinoma. Well, that's the end of my cases. I hope this helped you. Again, you can't always make a very specific diagnosis off 2 images, but it leads you to think about things. You need to have your mind working and thinking, what is it that could be? What am I considering? What am I excluding? What am I counting in? And we'll see you again with next month's You Make the Call. Have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.